Hello, I'm Dr. Alketa Licollari. Today we are conducting an in-depth clinical review of a complex case involving Folliculitis Decalvans and concurrent male pattern hair loss. Our patient, Mr. Jeffrey, attended for a review of his long-standing Folliculitis Decalvans, a condition he has been managing for over a decade. The condition has been present since 2014. Recently, he reported that the symptoms have started to return over the last 2 months, following a significant flare last year. During that flare, he was diagnosed with MRSA and treated successfully with Clarithromycin. Recently, his GP prescribed clobetasol for returning symptoms. Crucially, this case involves both scarring and non-scarring alopecia. Understanding the clinical differences between these two is vital for prognosis and management. Scarring alopecia, like Folliculitis decalvans, involves permanent follicle destruction. Non-scarring types, like male pattern loss, involve follicle miniaturization but stay viable. A key clinical marker is the follicular openings. In FD, these are lost and replaced by scar tissue. In male pattern hair loss, the pores remain visible. On examination, Mr. Jeffrey shows clear areas of cicatricial alopecia within duration, reflecting the chronic neutrophilic inflammatory process of FD. We also observed follicular hyperkeratosis and scaling on the frontal area, which are typical signs of active inflammatory activity in these cases. The hallmark of FD is tufted or doll's hair appearance, whereas male pattern loss is characterized by progressive hair shaft miniaturization. Mr. Jeffrey also exhibits male pattern hair loss on the vertex. This follows a predictable genetic pattern, unlike the irregular patches of FD. Male pattern hair loss or androgenetic alopecia typically presents with a predictable receding hairline and thinning at the crown. Tritoscopy allows us to see the active margins of inflammation. Our examination of Mr. Jeffrey reveals specific diagnostic indicators. We see white dots, tufted hairs, and perifollicular erythema. Scattered pustules further confirm the clinical diagnosis of Folliculitis Decalvans. In contrast, his male pattern loss shows an azotopicosis, a significant variation in hair diameter without the destructive scarring seen in the FD patches. To summarize the differences, FD is scarring, irregular, and inflammatory, while MPHL is non-scarring, predictable, and usually asymptomatic. The pathophysiology of FD is a neutrophilic attack on the hair follicle bulge, where the stem cells reside, leading to permanent loss. It's likely an abnormal immune response to Staphylococcus aureus, which acts as a superantigen, driving this chronic cycle of destruction. Male pattern loss is different. It's driven by dihydrotestosterone or DHT, which miniaturizes the follicle bulb but leaves the stem cells intact. DHT shortens the growth phase, progressively producing finer hairs. This process is potentially reversible because the follicle itself is not destroyed. For FD, we must arrest inflammation to prevent expansion. We use long-term antibiotics like doxycycline for their anti-inflammatory properties. Doxycycline 100 milligrams daily functions here as a cytokine inhibitor. This anti-inflammatory use does not increase bacterial resistance. The plan is a 4-month course of doxycycline followed by a break, cycling the treatment as needed to manage flares long-term. For his male pattern hair loss, the goal is to halt further thinning and preserve the existing viable follicles. We discussed topical minoxidil 5% and oral finasteride. These treatments aim to block DHT and prolong the growth phase of the hair. A 6-month trial is needed for efficacy. I advised wearing gloves for application and monitoring for potential side effects like blood pressure changes. For recalcitrant FD, we also discussed advanced options like JAK inhibitors and PRP injections, providing a multimodal therapeutic approach. I must emphasize that hair transplantation is not appropriate for the scarred areas. Once a follicle is lost to FD, The loss is permanent. Success in these complex cases requires balancing aggressive anti-inflammatory control with consistent hormonal management for hair preservation, ongoing monitoring, including MRSA swabs if appropriate, and regular clinical reviews ensures we stay ahead of any potential flares. Managing overlapping scalp conditions is challenging but rewarding when we provide clarity on the different disease processes involved. Thank you for attending this masterclass. Together, we can provide the best possible care for complex dermatological patients.